Good afternoon, everyone. My name is Madison Ferguson. I am a nurse practitioner student at Arkansas State University. The research I have conducted is an analysis of childhood obesity screening rates among a suburban pediatric population. The mentors I've had throughout this process are Dr. Mark Foster, Dr. Christopher Jordan, Ms. Otisha Hadley, and Ms. Lauren Hancock. I hope you all enjoy. So this is an at-large view of the poster I created for my research. Throughout this presentation, I will be discussing each subtopic individually. With having a nursing background in pediatrics, working in Memphis, Tennessee, this is a topic I've become very passionate about, so I truly do hope that you enjoy. Okay, so let me give you a little background regarding childhood obesity and why it is of such importance. The prevalence of childhood obesity in the United States is about 18.5%, affecting nearly 13.7 million children and adolescents. We can narrow that number a little further, with research showing that children aged 10 to 17%, 31% of them are either overweight or obese. The percentage in Tennessee is actually higher than that, with 36% of their youth falling into that category. Now, why is this important? Well, obesity in childhood years is more likely to lead to multiple complications and disease processes as they reach adulthood. This includes adult obesity, cardiovascular disease, diabetes, musculoskeletal disorders, and even puts them at a greater risk of developing some forms of cancer. In an attempt to combat these statistics, the U.S. Preventative Service Task Force released a Grade B recommendation that all clinicians screen for obesity in children and adolescents over the age of 6 by the means of BMI, and then offer or refer them for comprehensive, intensive, and behavioral interventions to promote improvements in weight status. Research was conducted and showed that on the national level, about 88% were doing the annual screening. However, only 64% were offering some form of intervention, with only 7% offering intensive interventions that were recommended. The objective of this study was to compare the screening practices of the providers in a pediatric clinic in Southwest Tennessee with the national average discussed above. I then took one step further, analyzing and comparing interventions on those who received a positive screening for obesity to the national level. I narrowed my research parameters to only be conducted on children over the age of 6 who would present to the clinic for their annual well-child visit. From there, 50 random electronic medical records were selected and a retrospective chart review was performed. When compared to the national average of 88%, the clinic surpassed that standard, screening 98% of their patients for obesity by the means of BMI. Of these patients that were screened, 52% were either overweight or obese. 30% screened positive for obesity, with a BMI over the 95th percentile. Of those who were considered obese, the clinicians did provide education regarding a healthy diet, limited screen time, and proper exercise. ICD-10 code of Z71.3, which is dietary surveillance and counseling, was built on 100% of these visits. ICD-10 code Z71.82, which is exercise counseling, was only built on approximately 33%. Now, of those who were considered to be obese, only 6.7 of these children and or their parents were provided the recommended interventions or referrals recommended by the task force. This was slightly less than the national average of 7%. After reviewing these charts, I realized that there are many billable codes that can maximize reimbursement for these providers that were not being utilized. Education can and should be done on all of our patients, regardless of their BMI status. Therefore, services should be billed for. I have listed the codes below for your observation. Now, what are these intensive interventions that I've been speaking of? The task force conducted research that proved that greater than or equal to 26 contact hours, targeting both the parent and the child, either separately or together, and providing education regarding healthy eating, safe exercising, reading food labels, stimulus control, goal setting, rewarding, and supervised physical activity, resulted in weight loss. If done by the practitioner, it is billable, and I have provided the billable codes below. Now, Keep in mind this is often a multidisciplinary team approach, including pediatricians, physical therapists, psychologists, and dietitians. We should utilize these resources and our colleagues for the health of our patients. My goal in conducting this research was to address the need of yearly obesity screening and the importance of initiating an appropriate intervention plan to combat the childhood obesity epidemic. I want to thank you all for taking the time to listen to my presentation. May you have a blessed day.